Hi everyone. I hope you're all doing well. So I'm here, Dr. Samal Noria, with our first topic of the day. That will be from your chapter two of your Robbins pathology. So we will be following along the bigger version of Robbins, as you might call it, because there are like three or four different versions of Robbins pathology textbook. So I will be using the 11th edition of Robbins pathological basis of disease. So all of my PowerPoints are going to be based off from that textbook. So let's dive into our first topic of the day. So this is on cellular adaptations. Okay, and if you again, I have my email here for all of you. If you want to reach out directly, please feel free to reach out directly on this email. I keep a check on this email regularly, so please send me your comments and your thoughts on my email. So let's start with our first topic on cellular adaptations. This is the first topic that I always like to start off our discussion on, the first few chapters with. And this is the very initial change that you see in the cells the cells which are facing an external stimulus, right? So we will talk more about what are the stimuli and what are the definitions. So let's start with cell adaptations. So when any cell encounters physiological stress or a pathological stimulus, they undergo some changes, and these changes are called adaptations. Okay, and what I want you to understand is the goal of cell adaptations. Why is the cell changing now? Because there is something happening from within the cell or outside the cell, and the cell wants to sort of maintain its homeostatic state, right? So it's trying to maintain its new steady state and preserve its viability and function, right? So that is the attempt of the cell here to adapt to the situation, as you might call it. So adaptations, one important feature that I have highlighted here is adaptations are reversible changes. So reversible changes means whenever the stimulus is removed, stimulus might be within the cell or outside, like I said. I'll give you all those examples in a bit. But when you remove that stimulus, the cell can go back to its original normal state. Okay, so these are all reversible changes which might occur in size, number, phenotype, metabolic activity, functions of cell in response to changes in their environment. So any change that the cell would have additionally acquired while adapting to a situation, if you remove the stimulus that is causing that sort of change in the cell or adaptation of the cell, if you remove that stimulus, the cell can go back to its original state. Okay, so next is what I would want to learn is here that adaptations have like several distinct forms. What I want you to learn is these four names here. So hypertrophy, hyperplasia, atrophy, and metaplasia. Okay, so none of the other words that you probably come across while doing questions or reading your textbooks, they are not categorized under adaptation. These are the four principal adaptive, like pure adaptive responses that you should know and that you should learn. Okay, so we will learn all of these four in terms of their definitions. What are these? Okay, so what are the causes? So, like I said, I told you in my previous opening sort of discussion lecture that you should always think about etiology and then the mechanism, okay, morphology, and then look at the clinical picture and what has changed clinically, right? So we will do exactly the same with all of these four, okay? So what causes hypertrophy? What is the mechanism of hypertrophy? What are the features, clinical features, and morphological features of hypertrophy? And the same for all of these four, okay? So hypertrophy, hyperplasia, atrophy, metaplasia, this is going to be my discussion for the next few hours, okay, with you. So let's start with hypertrophy. So basically hypertrophy, hyper is when organs become big, right? So hypertrophy in very simple language, very simple terminology, if we break it down, hyper means more, right? And increase in size. So that is hypertrophy, increase in the size. If you look at this image, this will make it even easier for you. So these are the four normal cells that I have shown you here. Okay, so cell hypertrophy is cell number is still four, but each of them has increased in size. Whereas in hyperplasia, the cell size looks very similar to the original ones, right? These are four cells here. They become 6, right? So what has been shown here in cell hypertrophy, the number remains similar, size increases, but in hyperplasia, the size is mostly similar, but the number increases. Okay, so this is a very basic beginning concept with hypertrophy and hyperplasia. So hypertrophied organs will have larger cells. Okay, advanced studies and research has shown that sometimes hyperplasia and hypertrophy coexist in a tissue, right? So we'll keep talking about all those advanced things as we go along, but I would want you to learn the basics first. Okay, so now the question is, what principally is the mechanism of any cell undergoing hypertrophy, right? How does a cell increase in size? So the increase in size would happen if the cell manufactures more structural components within it, right? In easy words, let's say it will have to synthesize more proteins. Okay, so I would want you to learn this with hypertrophy. What is happening? Cell is growing bigger by making more proteins. Okay, this is the simplest language, simplest way that you can understand what's basically going on with hypertrophy. Of course, we can learn about the pathways which make those proteins and the different genes which will be activated. But if you understand that hypertrophy is cell growing big by making more proteins within it, they may be structural proteins, cytoplasmic proteins, all of them, right? It makes things easier, right? Another concept that I would want you to understand here is like you would like to ask me, okay, when would a cell undergo hypertrophy? What determines if cell undergoes hypertrophy or hyperplasia? So there is one basic principle that you can again learn here. So basically the cells which are capable of division, okay, they can respond to stress by undergoing sort of they will divide, right? If the cell can divide, it will divide and maybe also grow in size. So hyperplasia and hypertrophy can occur both together in the cells that can divide, whereas the cells which cannot divide, there are certain tissues which we categorize as non-dividing cells. For example, myocardial fibers, okay? They increase tissue mass because of hypertrophy. Okay, so if the cell can divide, it will undergo hyperplasia. If the cell cannot divide and you've categorized it as a non-dividing cell, it undergoes hypertrophy, right? And that's what I want you to understand here, that in certain tissues hyperplasia and hypertrophy might occur together. Okay, so cell increases in size as well as might increase in number, okay, depending on what has triggered that adaptation in the cell. We'll talk about that in a bit. Okay, so let me give you some examples and a little bit more on hypertrophy. So this is, as we said, increase in the size of an organ or tissue due to increase in the size of the cell. I believe you now know this. And this is going to be mediated by certain growth factors, certain chemicals that the cells release. These are called as cytokines, okay? And some other sort of stimulus acting on the cell, which would have activated certain genes in the cell. Activation of genes, as you know, leads to protein production or protein synthesis in the cell, right? So one important concept with hypertrophy is it is a result of increased cellular protein production. Please learn this. A lot of MCQs, a lot of questions have been asked just around this basic concept. Okay, they might not directly ask you a protein production. They might say increased transcription. They might say increased mRNA, right? So all of that is telling you that it's increased protein production, right? They may not say it directly. They might say it indirectly. That's what I'm trying to tell you here, okay? If you look at the picture here, so what have I shown you here? Somebody working out, lifting weights in a gym, doing some exercise, building muscles. So basically muscles grow bigger when somebody works out due to hypertrophy of the muscles. Okay. Uh, if you need an advanced concept while working out, is there a possibility that skeletal muscles can divide? Some research says that there is a minimal possibility of that. Sometimes the cells can, muscular cells, skeletal muscle cells can also divide. But for the sake of your MCQs, we would say, okay, that most of the change that you see in increased skeletal muscles is because of hypertrophy. Okay, but you should also know that if I say out of 100% cell, the muscles have grown bigger, so 95% is hypertrophy, maybe 4 to 5% of hyperplasia is also possible. Okay. But you can say predominantly cells have grown in size because of hypertrophy. Next, we can talk about the types of hypertrophy. So it can be a physiological process or it can be a pathological process. Okay, so let's see is what are the examples of physiological hypertrophy, what are the examples of pathological hypertrophy, right? So hypertrophy of skeletal muscles, which I just discussed right now, in bodybuilders and somebody working out in a gym, right, lifting weights. These are examples of physiological hypertrophy. In the cells, like I said, cells are growing big by doing what? They have to generate more energy, they have to make more protein. So certainly if you look at the cell organelles, and you might notice that in these cells, okay, protein production is going on, and the powerhouse, the mitochondria of the cell, right, they would have increased in number in the cell. Okay, so another example that I would want to quote here is physiological growth of uterus during pregnancy, right? This is very interesting. Okay, so the smooth muscle cells, they undergo both hypertrophy as well as hyperplasia, right? I have put up a picture from your Robbins textbook here just to show you. So these are two, this is gravid uterus. So this is a pregnant uterus here, okay? And this one, the smaller one, is what the normal size of the uterus is. Do you notice how big it can grow now in size? Because this happens during pregnancy, right? So these are two uterus here in this first picture. So this is the one, which is a gravid or a pregnant uterus, right? So this is the gross appearance, right? So you see it is 10 to 15 times or even bigger than, what the normal looks like. The next two images are again, if you want to compare the histology and the smooth muscle cells that you would have seen under your microscope from a normal uterus, okay, versus the one which has undergone hypertrophy, okay? So if you look at this second image here in the center, these are all spindle shaped smooth muscle cells. You notice these nuclei, so many cells are shown here. If you look here on the third image and do a comparison, okay, so look at just one size, one cell size is almost like, I think, again, 15 times at least bigger than what the normal cell looks like. Okay, so this is what happens. These are large, you can say large plump cells from the gravid uterus, and both of these images are at the same magnification. So it's not that we have magnified more in the third one and not in the second one. So both these images are at the same magnification. So clearly you can see how much the cell size has increased here, right? Okay. Pathological hypertrophy. So when I say pathological hypertrophy, that means there is some abnormality or there is some disease process. Okay. So there is some disruption in the normal physiological process which would have led to this hypertrophy. Okay. One example, again, you should always remember, and this is very direct and very easy, and you can correlate with this, with your knowledge from physiology. Left ventricular hypertrophy in a person who has systemic hypertension, right? So in a hypertensive person, what would have happened? So there are different types of hypertension. We can talk about that, but let's say somebody having a systemic hypertension, heart would have to pump blood against higher pressure, right? So to do that, the cardiac muscles, because they are facing that additional pressure and they have to pump against it, they grow in size. So this image is a cross section or cut section showing you, okay, the increase in the muscle thickness in the left ventricle. So because left ventricle is the one pumping blood out to the body, right? If there is more blood pressure happening in the body, then the heart muscles, they have to grow big. Okay. Easy, right? And interesting also. So how does this happen? Let's get a little bit into mechanism now. So this is related to growth factor stimulation. For example, TGF beta would have increased, insulin-like growth factors, IGFs would have increased, FGFs would have increased. Okay, I'll show you the and talk about more in this image here. And all of this stimulation to each cardiac muscle cell would have led to activation of certain pathways. Pathways means some genes have been activated and eventually more protein production is going to happen. So more transcription factors formed, and eventually more protein production is going to take place by another, we can say that there would be increased mRNA again in the cell. This is again more protein production in the cell. I would want to bring your focus on this image here that I've again taken from your Robbins textbook. So if you see, what we have done is we have drawn one cell here. This blue structure is one cell. You can imagine a cardiac muscle cell if you want to. Okay. So what you see here on the surface of this cell, you see there are certain receptors shown here. So the first one, sorry, the first one shown here is a mechanical sensor, okay, which might belong to a family of proteins called as integrins, okay? So these act as stretch receptors. So what is a stretch receptor? It senses if the cell is being stretched, okay? Why and what is the stretch? What is causing the stretch? So I asked you to imagine that this is, and believe this is a cardiac myocyte cell which is facing more pressure. So more pressure on the outside because of this person has hypertension, right? We already said that. So the cell is being stretched on the surface, and the cell being stretched means these mechanical sensors are being stretched and they get activated by that stretch. So when they get stressed, what they do is they activate certain signal transduction pathways. Activation of these signal transduction pathways will lead to more protein production through activation of certain other genes. And if you want, you can memorize and try to learn some of these transcription factor names. This is GATF4, NFAT, MEF2. If not, I would want you to learn the concept first. What is happening? There are certain stretch receptors and they have activated transcription factors. Transcription factors, again, will help the cell make more protein, right? And this is now very interesting. What type of protein are being made in the cell? So as you see, there is another signal that is shown here on the surface of the cell with some alpha adrenergic hormones or through angiotensin. So this is another sort of receptor shown on the cell wall here. Again, helps in activation of these same signal transduction pathways. And all of this leads to protein production, but also leads to production of more growth factors. More growth factors, you know how growth factors act? Any cell which is trying to grow might produce growth factors, and growth factors, they go and act on the growth factor receptor on the same cell as well as the neighboring cell. Okay, so growth factors might be, it might be a situation the cell is producing its own growth factors. Okay, so growth signals activate production of growth factors. And in the middle, if you see, there is one very important thing, increased synthesis of contractile proteins. So what has happened here, this cell started making more growth factors. This cell started synthesizing more contractile proteins. And another very interesting thing that has happened here, this cell has induced. So you see what it says, induction of embryonic or fetal genes. So certain genes in their fetal forms or embryonic form of certain genes or certain proteins in their fetal form. So in the fetal stage, we have certain forms of some proteins. In adult, sometimes we have different forms, right? So this cell would have brought back or activated production of more of those certain fetal type of genes to produce fetal type of proteins. Why would a cell want to do that? A simple answer is those proteins are probably better at handling mechanical workload. Okay, so they are better at handling and working against that pressure and use less oxygen. That's also, another thing that has happened here. So we have activated proteins which can handle workload better by using less oxygen. Okay, so they can work better under that pressure situation. We have also activated through these pathways, we are making more contractile proteins and we are producing more growth factors. So that is what the cell is doing when it is stimulated by that external pressure. Uh, because of hypertension. Okay, so I think this is clear. So this is again one very specific thing which happens in cardiac hypertrophy. So when cardiac muscle cells, like I said, they grow big. So one of the changes that happens is switching of contractile proteins, and some alpha isoforms of myosin heavy chains might be replaced by the beta isoform, which I just told you have a slower, more energetically economical contraction. They can, contract well. They can use less oxygen, they contract better, right? So they are better at handling this extra workload that all of these cells are facing. Okay, so these are the bigger sized cells shown to you here in this image. Okay, so let me show you one more example of pathological hypertrophy. This is a section specimen of urinary bladder. Okay, so what this arrow is pointing towards is this is the prostate. Okay, so we've sort of opened up the bladder. So these are the two sort of halves, you can say, of the prostate gland, and it probably this patient would have had increased size of the prostate. Okay, so that happens as males age, right? So it happens in more than 80% of males. Okay, we'll talk more about that in male reproductive system, but this is what has happened here. So prostate is bigger. So because of bigger prostate, what has probably happened here is this patient would have had retention of urine, a lot of pressure built up inside the urinary bladder because the urethra goes through the prostate. Prostate has become bigger, which has constricted the urethra, which passes through it. Okay, so that increases the pressure on the cells in the urinary bladder wall, and they undergo. So the wall has smooth muscle cells, which will undergo hypertrophy. Okay, so that is what is being shown to you here. Okay. Let's look at one of the MCQs that I have for you today. So let's spend a minute reading this question. You can pause the video if you wish to. Let me read this question for you. 48-year-old man is evaluated for progressive exertional dyspnea. He has a history of untreated hypertension. Okay. Echocardiography reveals concentric thickening of the left ventricular wall with reduced compliance. Biopsy of myocardial tissue shows enlarged myocytes with enlarged nuclei. So whenever clinical information is given along with imaging and biopsy, I think uh, correlating everything can really help you if you are really sort of uh, if you want to be very good at diagnosis. And in the question, if biopsy is given, I think it reveals everything. So in this case, biopsy of myocardial tissue is showing you enlarged myocytes with enlarged nuclei. Okay, so there is certainly some increase in the size of the cell that has happened here. That is what this last lead-in says. Okay, and this is a 48-year-old. What has he come to you with? So this man has come with progressive exertional dyspnea, right? So difficulty breathing on exertion, that is what this means. Okay. This might be due to many reasons, but most likely this looks like this person has some, cardiac hypertension or early forms of sort of heart failure or initial forms of heart sort of failure that is going on here. Okay, he has a history of untreated hypertension, so that might have led to his sort of cardiac situation. Okay, and progressive dyspnea would have occurred because of back pressure building up in the lungs because of that situation, that early sort of heart failure situation causing that dyspnea. Why would this person have difficulty breathing? Because backup pressure is happening within the lungs. Because if you connect the entire system, heart and the lungs work as like two components of one machine, right? I like to explain it that way. So the lungs are pumping blood to the heart. Of course, heart is pumping blood to the lungs for oxygenation, but once it is oxygenated, the heart gets its oxygenated blood back from the lungs. If heart is failing, back pressure builds up in the lungs, right? So that is the cause of this patient's exertional dyspnea. Okay, sorry. So now the question asks us which of the following molecular mechanisms is most directly contributes to this adaptation. So definitely they've given us a hint in this question. They've asked us what is this adaptation, and moreover, they're asking us the mechanism of it. Okay. So if we can figure out what adaptation is this, we can, of course, get to the answer. So let's look at the answer choices. Increased rate of mitosis and entry into S phase. Option B, activation of transcription factors leading to increased protein synthesis. Option C, recruitment of stem cells from adjacent tissues. Option D, reprogramming of differentiated fibroblast into cardiomyocytes. Option E says deposition of extracellular matrix by activated myofibroblasts. Okay. So if you would have figured out by now, this is basically hypertension. Hypertension leads to cardiac muscle cell hypertrophy. So now we need to pick which option fits best, which explains the mechanism of hypertrophy. So I think all of you, if you were listening carefully, you would have picked the right answer. Okay, so right answer is on option B, which is activation of transcription factors leading to increased protein synthesis. And this is the very, very basic central idea I would want you to learn today for hypertrophy. Okay. So increased rate of mitosis would have meant, that is option A, would have meant more cells dividing, but that is not the case here. Recruitment of stem cells from adjacent tissues has not happened here. Okay, reprogramming of differentiated fibroblast. No, this is not that one cell has changed into another. No, deposits of extracellular matrix. This is not fibrosis. This option E tells you about collagen deposition and fibrosis. So that is not the case here. This is purely hypertrophy. Okay. Again, please review this. So you've already looked at this. We've talked about this. So mechanism of hypertrophy is an important thing that you should learn today. Okay, with this said, I think we can get to our next cell adaptation, which is hyperplasia. Okay, so let's look at the definitions of hyperplasia. So this is increase in the size of an organ or tissue caused by an increase in the number of cells. Okay, so hypertrophy was increase in the size. This is going to be about the number of cells. So this is where the cells will divide. And when we say cells will divide, means the cells which are capable of dividing, of course. Hyperplasia is an increase in the number of cells in an organ or tissue in response to a stimulus. And okay, so what is the mechanism of it? Okay, again, increased production of growth factors and hormones. I would want you to remember this. Growth factors, hormones acting on hormonal sensitive tissues. So whenever you're talking about any hormones acting on a cell, okay, let's start thinking of, the maybe you can think about the glandular tissues or tissues in the body which respond to hormones. Most of them undergo hyperplasia. Okay, so action of growth factors and hormones leads to activation of, again, intracellular pathways, which leads to cell division. Okay, so again, I told you hyperplasia, hypertrophy are distinct processes, but also overlap. Okay, sometimes depending on what tissue you are looking at. Okay, and hyperplasia, again, I've told you this fact, happens where the cells are capable of dividing, and thus the cell number increases in that tissue. It can again be physiologic or pathologic, so happening in a normal situation or a part of disease process. So we need to learn the examples for both of these now. So let's look at physiological hyperplasia. Again, this is due to action of hormones or growth factors whenever there is a need to increase the functional capacity of, the hormonally sensitive organs. This makes sense, right? Whenever there is a need for, you know, compensatory increase, that might be another situation. So basically you can divide and you can learn this topic under sort of two subcategories. One of them is hormonal hyperplasia. Hormonal is, of course, the name tells you, because of hormone production. Compensatory is some compensation process. For example, regeneration of liver happens following partial hepatectomies. Partially somebody has donated liver, or partly the liver has been removed because of any disease process. The rest of the liver can regenerate. Hormonal hyperplasia example, the best one is, and I would want you to remember. So there are many. So proliferation of glandular epithelium of female breast at puberty. So that would lead to lobular hyperplasia. Pregnancy, again, all of these are physiological examples of hyperplasia. So pregnancy, pregnant uterus, I told you it is both hypertrophy as well as hyperplasia. Another example that I would want you to always remember is about bone marrow. In hematology, this concept is very important. We will almost talk every day about, the hyperplasia happening in the bone marrow, right? So bone marrow is also, it has a very high capacity to sort of, undergo rapid hyperplasia to restore cells. So that can happen in many situations to just, produce more cells. If some certain cells are lost or they die in the blood, bone marrow is the production house which compensates and replaces all those cells, right? So in some diseases where RBCs are breaking down or hemolysis might be happening, so again, the bone marrow can undergo more cell division and, make more cells. And of course, it uses growth factors. One of the important growth factors is erythropoietin. So erythropoietin production happens in the kidneys, and that goes and acts on the RBC blasts, right? So those erythroblasts, they have receptors for erythropoietin, and then the cell division can happen, and that is how the compensation happens. And we will talk about all of this in hematology more, but please learn this as an example for now, okay? Very importantly, and that's where I've put up all these stars for you. So this red star means this is an important MCQ and has been repeatedly asked in your exams as a question, something about pathological hyperplasia. So pathological hyperplasia means excessive cell division happening in a tissue, right? And one example that I always want you to remember and always quote here is about endometrial hyperplasia. This is a very high topic, very important question. Okay, has been repeatedly asked over the past few years, and many years this has been a repeated question in your exam. So endometrial hyperplasia is an example of abnormal hormone-induced hyperplasia. Okay, this happens because of unopposed, okay, I'm using that word, unopposed excessive estrogen acting on the endometrium. Okay, so if there is unopposed excessive level of, estrogen acting on the endometrium, it undergoes excessive cell division. Why is this a very high yield topic? Why is this important? What are the questions they have asked you? Endometrial hyperplasia, because of that high cell turnover and rapid sort of production of new cells, has a sort of, it's a condition that might transform into endometrial adenocarcinoma. So this might convert into a cancer, right? That is why this is important. One concept that you can also learn here is, and it might help you somewhere. Any process where cell division increases, there is a lot of increased chances of cancers happening, okay, in those situations. So this is one of them. Another example that I've quoted here is prostatic hyperplasia. So prostate, again, because of increased and prolonged testosterone stimulation, so the cells can increase in number, right? Viral infections, certain infections, for example, HPV, human papilloma virus, cause skin warts, right? What are the skin warts? Skin warts are, again, epithelial hyperplasia keeps happening at increases in size, and then it becomes a benign sort of lesion on the skin, right? So we'll talk more about this in detail when we talk about the dermatopathology, okay? So again, please learn this endometrial hyperplasia. Why? Because it has a very high chance of turning into an adenocarcinoma. So there is a basically very much increased risk of endometrial carcinoma because of that unopposed estrogen action. And what I've done is I have put two pictures here on the like same magnification. These are sections from endometrium. So on the left side, you see normal endometrium. So the structure is, you see these round structures, all of these are glands, and the connective tissue is called stroma. That is the terminology we use for endometrial tissue, right? On the right side, same magnification image, but what you see here is very much increased number of glands. This is what happens during endometrial hyperplasia, and this has happened because of excessive estrogen stimulation. If this estrogen stimulation is taken away from this endometrium, I told you adaptations are reversible, so this will reverse back to normal. All adaptations are reversible, remember? But if this keeps going on for a very prolonged time, it might turn into this adenocarcinoma, which is not going to be reversible. Cancers are not reversible. Okay, that is something that we will discuss in the future chapters. Another example picture. So this is normal prostate here. This is the bladder. This is the prostate here. This tissue here. And on the right side, you see this is enlarged prostate. This is again because of testosterone. We'll talk about that. Microscopy is very important, and I would love like you to sort of remember this one fact about prostatic hyperplasia. So what you see are glands here. So all of these are glands. All of these are glands. Okay. Prostate glands, if you remember your histology now, which is important, prostate glands are lined by two layers of cells. Okay, so one is a basal layer, another is sort of the luminal layer, and one is sort of cuboidal, another is sort of columnar, right? You see both layers inside these cells. So we know this is, a normal sort of gland, but increased in numbers. So that tells us this is hyperplasia. What is the importance of two layers of cells? So we'll talk in more about this in male reproductive when we talk about prostate cancer. So if prostate cancers happen, prostate cancers, these glands, they lose one of the layers. So that is why this is important. And I wanted you to learn this. Okay. So that was about hyperplasia. I think now we can get to the next topic, the next uh, adaptation for today, which is